Want to bring everybody up at the same time? That might be easier. I'm going to speak very quickly and not very long, because in these kind of meetings I feel that the questions we get from the audience are much more important and lead us to where you want to go better than us standing up here and talking. I can talk about 2009 and 2116 for about 2 hours very easily. I won't put you through that. We went into the session with some very high hopes about healthcare, where we might be able to go. And you know, we usually go in these sessions, and if you get 50% of what you're going for, you feel pretty good. If you get 75%, it's a great victory. In this last session, we really rolled the table. We got everything we went in for. We got every single thing we wanted. I'm not going to tell you it was easy, because it wasn't. 2116 was almost 4 months of bare-knuckle negotiation with hospitals and insurers. Betsy Johnson and myself from the Senate, Mitch Greenleaf and Mary Nolan from the House. By the time we got through that, all 4 of us weren't even talking to each other, let alone the other side. But in the end, we got the bill through. Basically, what we do with that bill, as Rich has already talked about, is we take a loan from the hospitals by taxing them, give them that money right back again, and match it up with federal dollars at a 2-to-1 match. Over the next 4 years, it'll be about $3.5 billion for healthcare in Oregon that we wouldn't have gotten otherwise. That, along with the premium tax of 1%, and I always try to put that in perspective. Premiums are going up 10, 15, 20% a year. This is going to add 1% to that 10 or 15%. We match that also with the same federal match of 2-to-1. The money comes back to the insurers by them having more people insured and by lowering the cost curve of the uninsured. So it's a win-win for all sides. That money, along with the provider tax, will be used to insure every child in Oregon in the next 18 months. We'll have everybody insured for the first time. Every child in Oregon will have health insurance. We're also going to increase the number of adults in the Oregon Health Plan by 30 or 40,000, maybe slightly more than that. And we'll really start beefing up a program that allows small business owners to be able to subsidize premiums they pay at a pretty high level for people making less than 300% of the federal poverty level. So Oregon is one of the few states, as far as I know, the only state that actually has moved forward during this recession. We actually have increased the number of people in insured population through the state programs, and we continue to do that. This is a sustainable program. It's one that's going to be set for the next 4 years, and I think it will be probably renewed at that time when the 4 years is up. So it's not something that's a one-time shot. This is the real deal. I don't think we'll see kids in the state of Oregon uninsured again in the foreseeable future, no matter what the feds do or don't do. The other half, of course, is 2009. If you guys want to have a real good read some night when you can't sleep and you don't want to use Ambien, pick up 2009. There's 600 pages there for you. The first 50 pages are the real bill. And I'm just going to give you an example of what the bill does and what we're trying to do with that bill. There are 3 issues in healthcare, really. One is coverage. We want everybody covered in one way or another through a public plan or a private plan. We want people to have choice in that. So 2009 lays that out. That's going to happen probably within the next 18 to 24 months. The second thing we have to do is get more accountability and better quality from healthcare. The disparity in healthcare as far as quality is concerned across Oregon and across the United States is horrendous. And we need to get best practices in place, best outcomes in place, and 2009 allows us to do that. And the third thing is cost. Cost in America is 40 to 50% or more than any other nation in the world, with some of the worst outcomes in the world. We rank about 40th in the world in industrialized countries as far as outcomes are concerned. 2009 starts addressing those cost issues also. And I'll give you just one quick example of that so it kind of is meaningful for you. Knowing there's 50 pages of ideas built into this, I want to talk to you about some end-of-life issues. We presently have a system in Oregon called a PULSE form. It's a pink sheet of paper. Some of you may have seen it. And in that, the individual patient can mark there what they want done if they're found unconscious and can't speak for themselves. Great idea. It works well. We've got a high penetration for people over the age of 70 with this, and some even in the lower ages, in 50s and 60s. When they come to the emergency room and I'm standing there in front of the patient, this has happened, and the patient can't speak for themselves, I always ask for the PULSE form. But usually it's not there. It's in a drawer somewhere at home. You know, it's a big pink form. Most people don't like to put that on the refrigerator where everybody sees it when you come to dinner. You know, Grandma says she doesn't want to be resuscitated if she dies. Well, that's nice. What's for dinner? You know, kind of ruins the evening. So people put it away, but you can't find it then when you need it. And I often will take a patient and put them up in ICU because we don't know what's going on, put them on a respirator, put all kinds of tubes and everything into them, resuscitate them as best we can. They usually don't wake up. And then 3 or 4 days later, a family member brings the pulse form in. We find out that the gentleman or the lady involved didn't want anything done. We've just spent $300,000 on somebody and tortured them when they didn't want it done. And that's something we want to change. So one day I'm out changing my irrigation pipe in my field. It's sort of a mindless job that I do twice a week. I do a lot of mindless things twice a week, but this one I do quite a bit. And it strikes me that in my office, if I have a child come to me and they want to be immunized, I can go on the internet and immediately find out, because we have a statewide registry, what that child's needs are as far as immunization is concerned, which is kind of a complicated situation nowadays. But if someone comes to the emergency room for me with something much more important of what they want done at the end of their life, or potentially the end of their life, I don't know. So I had the bright idea that we should put this on the internet and put it in a registry. And so we went ahead and put that in 2009, and we have the beginning of the pilot program that's being implemented already in Clackamas County, started about 2 months ago. So when the emergency team gets to your house, they've already got a handheld device that tells them what you want done. So when they walk in your home, if you're down, they know what you want done. You may want everything done. That's great. We'll do it. You may want limited things done. We'll do that. You may want nothing done. And that's going to change what we're going to be doing in healthcare. And we want to be able to do what the patient wants us to do and not something that they don't want done. That's a cost-saving device, obviously, but we're not doing it for that reason. We're doing it because we want to honor what the patient wants done. So that's an example of one thing we're doing in 2009. It's already being implemented. It'll go statewide probably within the next 18 months also. And there's a whole bunch of other things in there. I'm not going to go through them all, but I wanted to give you that example as a good idea of what we're doing. What are we going to do next? We still have a huge number of uninsured people in Oregon. This morning in my practice, I saw a man I hadn't seen for 3 years. He had 5 stents put in his heart 4 years ago, and lost his insurance 3 years ago. And so he stopped taking all his hypertensive medications, stopped taking all his medications that lowered his cholesterol, and then over the weekend he had an episode of huge chest pain and hypertension. Seen in the emergency room, put in the hospital for 2 days. He knew he couldn't afford it, so he checked himself out and came and saw me today. Okay? Blood pressure off the map. I don't know what his cholesterol looks like. So we got him all fixed up with medication and took care of him. Hopefully he has not had a heart attack again. But this is the kind of thing we have to stop. Preventative medicine for this man would have prevented what happened over the weekend. We just spent $20,000 or $30,000 on somebody who we could have spent maybe $2,000 or $3,000 on over the last 5 years and prevented everything he went through. He's 56 years old. He's self-employed. He works hard every day. And he can't afford health insurance. So that's our next target. Our next target is this group of men and women who are below and above the poverty level. Most of them are hardworking Oregonians. They've got jobs. They can't afford health care. We are going to open that up to them by supplementing private health insurance and producing a public program that they can buy into at a reasonable cost. And we're going to get that done, I believe, by 2015. And we're hoping for a lot of federal help in doing that, which I think is coming. The federal government has, as we do in Oregon, a real challenge with people having different ideas and what should be the right thing to do and reaching a reasonable compromise without bringing any guns out. I tell everybody in the House and Senate up in Salem, there's 60 people in the House, there's 30 people in the Senate, and there's a governor. You would think that would give you 91 opinions. Actually, it gives you about 200 because most of us are schizophrenic. So, you know, you got to get everybody roped together and get into a common cause and understand you have to come up with a common plan. And I think that's what the feds will do. I've seen some early things that look very promising. I'm hoping for some shots at a Medicare waiver, possibly. I want some ERISA relief. I want some other things happening. Write these things down, okay? And we're looking very, very much forward to seeing what happens come out in probably in September, October. And we are ready to take that challenge on and work with the federal government to close the final gap as far as cost is concerned, as far as quality is concerned, and most importantly, to make sure everybody has a reasonable health insurance.
All right.
Mary Beth, I'm going to leave it to you now.
All right.
Thank you.